Now I call upon Dr. Nimitha Nageeb to present case.
So, first of all, I would like to thank Bindu Madam and KSOS for this opportunity. I'll be presenting a case on tab acetazolamide. So, this is a 53-year-old male hypertensive who came with sudden painless diminution of vision and associated with pain and redness, 2-day duration. He consulted a local eye hospital where he was found to have increased intraocular pressure and was given a single tab Diamox and advised YAG PI. He underwent post-myringotomy surgery 7 months back. So on examination, the vision was 612 and IOP was 44 and 40. Anterior segment, there was mild congestion and AC was shallow. Pupil was about 4 millimeter dilated and gonio was closed. The fundus showed 0.6 cupping and shallow CDs. This is a fundus picture of shallow CDs. And B scan was done, which showed shallow CD, and RCS measurement was also taken, where right eye was 1.82 and left eye was 2.29. Axial length was also done, that showed 24.47 and left eye 24.33. ASOCT showed ciliocoroidal effusion. Considering the choroidal detachment, shallow AC and high IOP, the differential diagnosis of weakage and uveal effusion syndrome was also ruled out. FFA showed no signs of inflammation. The diagnosis was mainly acetazolamide-induced angle closure, and he was treated with topical antibiotic steroids, cycloplegics, and timolol. And the offending drug acetazolamide was discontinued. So on day 4, his vision improved to 6.6 and IOP was reduced to 11 and the CDs were resolved. This is the ASOCT picture showing resolved ciliocoroidal effusion. So the drugs causing secondary acute angle closure, it could be either pupillary block mechanism, that is it could be alpha agonist, beta adrenergics, or cholinergics, anticholinergics, or it could be due to an idiosyncratic reaction, that is the sulfa-based drugs like topiramate, acetazolamide, hydrochlorothiazide, and also anticoagulants can cause hemorrhagic CDs leading to acute angle closure, secondary acute angle closure. So what is the cause of ciliocoroidal effusion? It's basically idiosyncratic reaction which is causing sudden breakdown of the blood aqueous barrier. There is also vitreous dehydration and expansion of the extravascular tissue of the ciliary body, causing ciliary body edema. The next, the mechanism of bilateral angle closure, it's basically because of ciliary body swelling and ciliocoroidal effusion. There is anterior rotation of the ciliary body, forward displacement of the lens iris diaphragm, and acute angle closure. So the forward displacement of the lens iris diaphragm, the zonal tension decreases, there is thickening of the lens, and also there is induced myopia. So there are various case reports seen after like a single dose of acetazolamide after cataract surgery, ciliocoroidal effusion was noted. And also this is a case report of a COVID-19 patient who was treated with low molecular weight heparin. She was misdiagnosed as having conjunctivitis, and bilateral acute angle closure was so basically the heparin was made. So basically the drug which is used to treat IOP caused ciliocoroidal effusion, and there's a fine line between acute primary angle closure and acute secondary angle closure. And if we do pilocarpine and LPI, it can be detrimental in these patients. Patient should be educated about the warning symptoms, and early identification can prevent vision-threatening sequelae. Thank you.
Like a case of angle closure glaucoma before acute attack of angle closure glaucoma, is it necessary to do an ASOCT or a B scan before we go in for a LPI?
Not really. One thing, when you started the case, the patient came to you with high IOP and on Diamox.
Yeah,
But
previous day he had consulted a local hospital where he was given an initial dose of Diamox.
But then that means before Diamox itself his pressure was high, no? What would have been the reason? Why did that doctor give Diamox? That was little intriguing. So one more thing probably we should think is in such times when they come like this and then you diagnose drug induced, again you have to go back and recheck your gonio whether there was an angle closure which was treated with Diamox. It can precipitate drug induced angle closure also. So you have to re-evaluate your gonio and then decide whether is it really a PSC or PSCS or what is the reason for the high IOP.
It's actually a good point to be noted that when you said Diamox was given by an ophthalmologist, only one dose. Usually you'll have one is the inciting dose and a precipitating dose. 2 doses, or the patient must have taken a Diamox sometime earlier. Then the patient will develop, for the first tablet itself, they will develop a idiosyncratic reaction. But very curious question is again like what she asked. When the patient was presented to the ophthalmologist, already he had a higher IOP. So what was the reason for that? We don't know. That we'll have to really evaluate. One thing. Second thing is...
Sir, actually after this he was evaluated. His angles were open.
No, that is
actually.
fine.
Yeah.
Angles were open, it is all fine.
Yeah.
But what was the dose that or the medication that he or she has received to have the idiosyncratic reaction is the question now. Is it Diamox somebody has given earlier, or he has taken the Diamox sometime earlier? We don't know that part of it. But when they presented to the doctor, IOPs were higher, that is why the Diamox was given. Alright. Then the next thing is it was looking more obviously drug induced because the clinical picture is more so for the drug induced secondary angle closure glaucoma, and more so you had the choroidals, and as well as the eye will be very less congested with the corneal edema plus or minus depending upon the IOP levels. Pupil will be normal or slightly dilated, not like acute angle closure. Eye will be much more quieter. But if the refraction, if you have done, it could have been nicer to see how much was the induced myopia the patient had. 6.6, now suddenly dropping down to 660 with a -3, -4, -8. That could have even given you much more clues on it is drug induced or is it an acute, but doesn't look like an acute angle closure. Typically it is more like only a drug induced glaucoma. So usually, coming back to Bindu's thing, there is no need for you to do peripheral iridotomy in these cases when we are all normal like what we are all. I don't think you need to really go for doing an ASOCT or B scan and other things when you're giving the drug, because nobody knows who is going to have a idiosyncratic reaction for what. So I don't think we need to do in every given Diamox patients. If you start doing, you will be the multimillionaire like Ambani.
I think educating probably neurologists, because they are the ones who prescribe Diamox for other reasons, plus topiramate. These are one of the common things. So I think now more and more neurologists are referring to us just to make sure that there is no sign of angle closure. Because again, when the people who have, in fact, one of the primary reason to do a PI in PACS can be these kind of patients also.
So again, to go back to you, when the neurologist referring to you, is it that I do a scan or a B scan? I don't think you should do any scan. You are happy if the patient has a scan, operate on him.